and infection compartment syndrome, and those that occurring long time after injury, delayed union and non-union, and others like avascular necrosis, reflex sympathetic dystrophy, Volkmann's ischemic contracture, myositis ossificans, osteomyelitis, shortening, osteoarthritis, and the list goes on and on and on. So let's discuss about some of the key things that we can cover over the entire period, not making you the most of the bottom of it. So first is hemorrhagic or hypovolemic shock. What is shock? As we have studied in our physiology classes, it's inadequate perfusion and oxygenation to the tissues due to failure of circulatory system. So there is hypoxia that is being persisting in the vital organs. So there will be acidosis that is going to develop in the system. So this is the commonest cause of death following fracture, and there are different types of shocks like hypovolemic shock, cardiogenic shock, septic shock, neurogenic shock, and anaphylactic shock. So hypovolemic shock is when, because of bleeding, your because of the bleeding, the total body volume is getting reduced, and there is hypotension, tachycardia, as well as tachycardia and hypotension. So because of hypotension, the body is trying to cope up by increasing the heart rate because of the intact autonomic nervous system. Whereas neurogenic shock is mostly seen in a traumatic setup when you have spinal cord injury. In your spinal cord, you have your autonomic nervous system, which if it's deranged, you have your hypotension, but your autonomic nervous system is not trying to cope up your hypotension or your systemic circulation with your autonomic nervous system because it is deranged. So you can't have a tachycardia. So the body goes into bradycardia. The heart rate goes into bradycardia. So this is how we differentiate between hypovolemic shock and neurogenic shock. So these are the two key things with respect to shock that you essentially need to know with respect to a trauma setting. Now, what are the sources of hemorrhage? First is external hemorrhage. So if you have an open fracture, the source of hemorrhage is very evident. The bleeding site can be very evident in a trauma patient. Whereas there can be unrevealed sources of hemorrhages also, like blunt injury, abdomen or chest, or intracranial injury. There can be sources of internal bleeding, which you cannot pick up. The patient won't tell you, like, there is a bleeding source. Only what you can pick up is there will be a hypotension followed by a tachycardia, and you necessarily have to pick up with your clinical skills and with your imagings. So the approximate sources of blood losses are in a femoral shaft, a half a liter to 2 liter of blood loss is there. In pelvic fracture, 1 liter to 2.5 liters of blood loss is there. And tibial shaft ranges from 500 to 1500 ml. So this accounts for a significant loss of your blood loss. Now, what are the clinical features? So as we have mentioned, there will be hypotension. So in order to compensate that, there will be tachycardia. So what the body tries to do is, first, the body tries to pull up all the blood back to the heart, so that the systemic circulation is getting maintained. So the peripheral circulation is getting reduced. So you got to have a cold, clammy skin, moist skin, and all your peripheral circulation is getting reduced. You will have your renal shutdown that is going to start in the form of reduced urine output initially. Then your creat levels will start going up. Your sensorium, you will have clouding of sensorium. Then your GCS will gradually deteriorate over a period of time. You will have your respiratory efforts will get reduced. So these are the peripheral way of having the manifestation. So first, the key points is hypotension and tachycardia and peripheral shutdown. For if you don't correct the shock per se, the hypovolemic shock per se. So this slide, you can take a snapshot of it. How do we classify hypovolemic shock, like class 1, 2, 3, and 4? So essentially, first we will have a pulse rate that is less than 100. So if the blood loss is less than up to 15%, so then the BP will be normal. But as we go up, like for example, as the blood loss is up to 30 to 40%, like in a class 3 shock, your pulse rate is going to above 120. That is a significant tachycardia. So, and again, your blood pressure is getting reduced. So this, up to this point, there will be a compensation that is again going. So the body is going into a compensated form. But as the blood loss is going much more ahead, the body is going into a decompensated form, in which the tachycardia is persisting, but the blood pressure is further going down, and the urine output and the patient is going to lose. So how do we manage initially? If the hypovolemia is less, we can manage it with the crystalloid, but as the severity increase, you need to replace it with the blood transfusion. So how do we manage? So basically, in a trauma setup, the basic dictum of basic life support has to be taken care of. You need to take care of the patient with respect to airway, breathing, circulation. So with respect to circulation, you need to monitor the arterial. An arterial line has to be secured, and arterial pressures and pulse oximeter for oxygenation has to be monitored, and ABG and serum electrolytes and blood counts should be monitored on an ICU setting, and head should be in a lowered position to avoid vasovagal syncope, and then respiratory support has to be given, and crystalloids and colloid support should be given. Blood transfusion, if significant, if you think that the class 3 or class 4 of hypovolemic shock is being setting in, and urine output has to be monitored to look for any sort of renal shutdown. And if any renal shutdown is being seen, it is an alarming thing that, see, you are going into a dangerous site. And bleeding site should be searched to look for any sort of unrevealed or any internal bleeding, like in thorax or abdomen or pelvis, and has to be taken care of. And a fractured limb has to be splintered, and if it's an open fracture, a wound debridement and an external fixation, so that has to be taken care of. External fixation means it's a temporary management, not a definitive fixation. So that is what has to be done on an emergency basis. So this is what is hypovolemic shock. So hypovolemic shock is, in a nutshell, it is basically your blood volume is getting reduced because of trauma. So etiology can be revealed hemorrhages, like in an open fracture, or an unrevealed, like your internal bleeding in your abdominal injury, chest injury, or intracranial injury. You need to know the essential classification system and how do we manage based on the severity of the injury, and your mechanism, like how the hypotension and tachycardia is occurring, and how do we differentiate between hypovolemic shock and neurogenic shock. I hope it's clear. Let's move on to the next topic, that is fat embolism syndrome. So I'll be discussing a very key exam oriented topics. So next is fat embolism syndrome. It manifests clinically as acute respiratory insufficiency. So what is fat embolism syndrome? So see, in a long bone, for example, in shaft of femur, you have your diaphysis. Within your diaphysis, you have your bone marrow. So in a long bone fracture, whenever you get a fracture, this bone marrow is getting disrupted. This bone marrow contains fat cells. This fat cells definitely gets dislodged, and this is essentially occurring in all sort of fracture, but that is not fat embolism syndrome. When this embolized fat, when it is going and obstructing the end capillaries of vital organs like your lungs or your brain or your retina, and causing a debilitating condition to the patient, then you call it as fat embolism syndrome. So it is manifest clinically as acute respiratory insufficiency when your pulmonary vasculature or pulmonary capillaries are getting obstructed by the fat embolus that is getting dislodged from the long bone marrow. I hope it's clear. So what are the causes? So as we have enumerated, fracture of long bones or following medullary reaming when you are doing a fixation, a surgical fixation, or when you do a joint replacement surgery, you essentially do a lot of reaming and cementation, following bone infarcts in multiple hemoglobinopathies, or in cases of burns, liposuction surgeries, neoplasm, severe infection, and blood transfusion, renal transplant, and collagen disease. So this essentially depicts what I have told a couple of slides before. So you have your long bone, within which you have your bone marrow, to which your nutrient arteries are going. When you get a fracture, when you get a fracture, see, when you get a fracture, the bone marrow dislodges into the vessels, the nutrient artery, as well as the vein, which can go into the systemic circulation and dislodge into the pulmonary vessels, into the end capillaries. So this can have varied sort of manifestation, this emboli can. So this sort of, what is a syndrome? It is not a specific thing. It can have different things. So this is what is fat embolism syndrome. Now, there are different, one is there are different varied sort of clinical presentation. One is, which has been classified as by CEVIT. One is subclinical FES, which is manifested by reduced saturation, hemoglobin is reduced, and reduced platelet, but there will be no clinical signs or symptoms of respiratory insufficiency. That is subclinical fat embolism syndrome. Now, there is non-fulminant fat embolism syndrome, where signs and symptoms are evident, and respiratory which is manifested as respiratory insufficiency when your lung and capillaries is being obstructed with the fat globules, and cerebral dysfunction when your intracranial capillaries are getting dislodged with the fat bone marrow, or your petechia, skin petechia can be seen clinically. Typical radiographs can be seen, like snowstorm appearance in your X-ray can be seen, and hematological changes can also be seen. So this is non-fulminant functional means fat embolism syndrome. Then there is another variant known as fulminant fat embolism syndrome, where the patient dies very rapidly. Like a trauma patient comes, a patient with a shaft of femur fracture comes to the casualty, the patient rapidly dies off, and these manifestation could not even be seen, and the patient goes into coma and throws off repeated seizures and collapses, and death supervenes suddenly. So this is what is known as fulminant fat embolism syndrome. So these are the three different types of clinical scenarios classified by CEVIT, so which is very important. So this is a pathological specimen showing petechiae, the capillaries on the within the cerebral hemisphere, showing petechiae. This is the snowstorm appearance that you can see on the X-ray. This is the subconjunctival hemorrhages that you can pick up, and the petechiae that you can see on the underneath the skin because of reduced platelet count, and the retinoscopy showing retinal bleeds. So onset of symptom is usually within 12 to 72 hours. So the patient has to be monitored. Any long bone fracture, patient has to be monitored for such symptoms, and may manifest as early as 6 hours and as late as 10 days. Arterial hypoxemia is the hallmark. So what is the classic triad? Pulmonary dysfunction, cerebral dysfunction, cutaneous changes. So fever, tachycardia, retinal changes, and renal changes. End organ changes can be then. Renal and hepatic changes can be seen. So what is the criteria to diagnose fat embolism syndrome? It's called Gertz criteria. So you need to have a major, minor, and lab feature. At least one major feature, at least 4 minor features, and at least 1 lab feature. What are the major criteria? One is respiratory insufficiency. Your lungs is getting affected. So saturation has to go down less than 60%. Cerebral dysfunction, GCS has to come down. Petechial rashes. So this is the major criteria. What are the minor criteria? At least 4 has to be seen. Fever more than 38.5 degree, tachycardia more than 140, retinal changes, and jaundice and renal changes. LFT has to go up and RFT has to derange. Lab features, anemia, HB drop has to be there. Thrombocytopenia, platelet has to come down. ESR has to go up, and fat macroglobulinemia in urine. So this you can take a snapshot. Gertz criteria, it's very important. So basically, the diagnosis is essentially clinical. you need to have a keen look on the patient for to look for any sort of petechiae or subconjunctival hemorrhage, deterioration of consciousness, increased respiratory rate. And again, the chest X-ray can show snowstorm appearance, and ECG shows a prominent S wave. Please don't ask an orthopedic surgeon what an S wave looks like. So then management essentially consists of early diagnosis and treatment. So maintain an airway uh, and fluid and electrolyte balance, and blood transfusion and immobilization of the fracture has to be done to avoid further embolization, and respiratory support has to be given to maintain an oxygen with 100% via mask or nasal cannula, and corticosteroids like methylprednisolone can be administered to reduce the inflammation. There has been studies showing ethanol bolus preventing the fat embolism syndrome by acting as lipase inhibitors, and heparin and dextran can be also used. Now coming to the next topic. So fat embolism syndrome in nutshell. So basically fat embolism is occurring in all sort of fractures, in all sort of long bone fractures. When is it happening as a fat embolism syndrome? When the fat is getting dislodged from the bone marrow to the systemic circulation, and when it is obstructing the end capillaries of your vital organs like your CNS, pulmonary circulation, and your retina, causing debilitating disease to the patient. So this is what is known as fat embolism syndrome. Essentially, you need to know your GERDS criteria and how do we manage basically to give supportive measures to the patient until and unless the inflammatory changes are going to come down to the end organs, which is going to be taking for 48 to 72 hours. So in the form of supportive measures and corticosteroids, and avoid further progression of the disease. So basically the patient needs an ICU management. So that is fat embolism syndrome in a nutshell. Now coming to the next topic, that is deep vein thrombosis and pulmonary embolism. I hope you guys are along with me. It's a common in lower limb injuries and pelvic fractures and spinal injuries. Basically, it's acute thrombosis of deep veins, of which is a serious life-threatening condition which can lead to sudden death in short-term or long-term morbidity. So basically, suppose if a patient with pelvic fracture or a neck of femur fracture, or say a shaft of femur fracture, or any patient, or a spine fracture, any patient who is having a fracture, who is going to be on bed for some time, what happens is that the his lower limb is going to be on the bed for some time without mobilization. So, and his bleeding parameters is going to be deranged. So then the coagulopathies are going to be deranged. There are chances of thrombosis that can occur because of the stasis. You know the Virchow's triad. When there is stasis, when there is hypercoagulopathy, there are additional chances of thrombosis to occur. So your deep vein is going to, there are chances of your deep vein going into thrombosis. So this is basically what is deep vein thrombosis. So when the most common site is your calf vein, deep calf veins. Suppose the patient is, this thrombosis is going to progress proximally or either dislodged because of further mobilization. What happens? This thrombus is going to dislodge into the inferior vena cava and can go into the lungs and cause right heart failure. So this is what is pulmonary embolism. So this is the pathomechanism in simple words. So this is a common complication. So 50% of patients develop DVT due to fractures in lower limb. 10% of these patients can go into pulmonary embolism and 2% can die. This is the statistics. So this is how a limb looks when you have DVT, swollen with a hyperthermia, when you palpate for severe tenderness. So this is how it looks like. And DVT can be recognized as early as 48 hours clinically, Pulmonary embolism, that is because which is manifested as shortness of breath, sudden collapse, usually develops 4 to 5 days after injury. First complaint will be edema, erythema, dilated veins of leg, dull aching or nagging pain in calf muscles, superficial blebs in skin, redness and warmth, low-grade fever with increased pulse rate is characteristic. And phlegmasia alba dolens, it's white leg when thrombus extends from calf to iliofemoral vein, and phlegmasia cirrhola, blue leg with loss of superficial tissues to the toes. So these are the two things that has been mentioned in the DAS textbook of surgery. And what are the signs that you can elicit for DVT? One is Homan's test, that is forceful dorsiflexion of the foot when knee is full in flex position, tenderness of the calf sign, or Moses sign, that is squeezing the calf can elicit tenderness. Now, what are the how do we confirm our diagnosis of clinical diagnosis of DVT? One is contrast venography. You can do the ultrasound Doppler to confirm. Now, once the diagnosis is made, you can you need to essentially treat the patient. So treatment consists of you need to make sure that the patient is taking bed rest and elevate the limb. You need to avoid the dislodgement of the thrombus. Suppose a patient with DVT is being mobilized. What happens? The thrombus can dislodge into the inferior vena cava and go into the pulmonary circulation. So, and again, this can cause increased pressure on your right heart. So a loading dose of, so you need to make sure that the patient is on the bed, elevate the limb, loading dose of 10,000 to 15,000 international unit of heparin is administered intravenously, and heparin treatment has to be continued 7 to 10 days. And heparin is a short acting drug, whereas warfarin is a takes some time to start. So before you withdraw the heparin, you need to start warfarin 2 to 3 days in advance. And you need to place inferior vena cava filters if there are chances of pulmonary embolism, if you think there is progression of thrombus proximally. So that is your deep vein thrombosis. Next is what is known as crush syndrome or traumatic rhabdomyolysis. So this refers to a sequelae of prolonged continuous pressure on muscle tissue. So it's systemically manifested as hyperkalemia, myoglobinemia, and anuric renal failure. So when you have a earthquake or a vehicle accident, or any compartment syndrome, when you're or any sort of prolonged muscle pressure, what happens is the muscle tissue is getting compressed, and all your intramuscular substances are getting pumped out into your systemic circulation, and this can result into renal failure. So this is essentially what is crush syndrome. So the electrolyte imbalance that are occurring is the hyperkalemia, hypocalcemia, metabolic acidosis, and phosphorus and magnesium imbalance. And essentially this can cause get result in renal failure. So management is basically the fluid and electrolyte management. Basically you need to give, it's an acidotic condition, so basically you need to give bicarb, and the hyperkalemia part has to be taken care of. And for local treatment, with respect to the systemic treatment, we need to take care of the electrolyte and systemic part. And with respect to the limb part, if the limb is salvageable, you need to do a fasciotomy and stabilize the fracture if there is a fracture. If the limb is severely crushed and it is going to cause additional injury to the life, or if the renal parameters are going to be worsened by preserving the limb, then the only option is amputation. So that is crush syndrome. Next important topic of is delayed union and non-union. What is delayed union? So implies that union will occur over a longer period than usual average rate for that location and type of fracture. So I hope you guys know regarding the stages of fracture, that is hematoma, stage of inflammation, stage of callus formation, consolidation, and remodeling. So whenever this stage is like usual stage of each stage has to occur, whenever the callus fails to occur or the consolidation fails to occur within the stipulated time. So consolidation has to usually occur usually within 3 months. So when this consolidation is not occurring usually within 3 months, you call it as a delayed union. So, and what is non-union? It's a complete suspension of process of healing at some time of osseous bridging of the defect. So delayed union means the process of healing is still there, but it's delayed. Whereas non-union means there is complete delay or halt in the progression of the healing. So non-union is a retrospective diagnosis. That is, the fracture has to be the non-union has to be established when a minimum of 9 months has to be completed following the injury, and fracture shows no signs for healing even for 3 months of follow-up. So this is the US FDA definition for non-union. This everyone has to know this definition of non-union. So what are the causes of delayed or non-union? So there can be causes related to the patient, causes related to the fracture, causes related to the treatment. So what are the causes related to the patient? Extremes of age, either you are in old age or very like young age, or poor nutrition, nicotine or alcohol consumption, associated illness, malignancy, osteomalacia, metabolic disorders, hyperparathyroidism, causes related to fractures, distraction of fracture site, pull of fragment, like when you have fracture patella, your quadriceps is getting pulled down at the either side. The tibial tuberosity as well as your quadriceps is getting pulled, or your fracture olecranon, your triceps is getting pulled out, or your gravity, fracture shaft of humerus, and soft tissue interposition is there in between your fracture site, or there is a bone loss at the fracture site when you have an open fracture, or there is an associated infection or loss of blood supply. There are some precarious sites like fracture neck of femur, fracture scaphoid, fracture talus. So these are loss of blood supply can occur, and damage of surrounding muscles. It's often told that fracture is often a part of the soft tissue injury. So if the surrounding soft tissue is damaged aggressively, then there can be a delayed or non-union. Pathological fracture. Suppose if there is a fracture following a neoplastic pathology or an intact fellow bone. Suppose if the tibia is fractured and the fibula is intact, the fibula is maintaining the length of the bone, the limb, and tibia is fractured and is separated. So that is intact fellow bone. The same is applicable to the forearm. So these are the causes related to the fracture, and causes related to the treatment. One is inadequate reduction, inadequate immobilization. You are not properly immobilizing for the particular period of time. Distraction during treatment, you are giving unnecessary distraction, you are distracting the fracture fragment. Improperly applied fixation devices. So we have discussed what are the sites that are precarious to fracture non-union. And diagnosis, there will be of non-union, there will be sense of weakness. On examination you won't have a tenderness. So non-union is essentially non-tender. There will be absent crepitus, and abnormal mobility will be there. You can freely move the fracture fragment. X-ray shows woolly appearance of bone ends, obliteration of medullary canal near bone fragments, and clear and wide fracture line. And delayed union shows fracture site tenderness. So this is how you clinically differentiate between delayed union and non-union. Delayed union will be tender to palpate for, whereas non-union is non-tender. And delayed union will have X-ray shows callus formation, but not up to expectation. So that is delayed union. Whereas non-union means there will be obliteration of medullary canal or woolly appearance. There will be woolly appearance of bone ends or clear or wide fracture line, or minimal or absent external callus. So management for the non-union is good reduction, bone grafting, and stabilization of the fragment by external or internal fixation. So how do we classify non-union? There are there is Muller and Weber classification, hypervascular and avascular. So hypervascular means your vascularity to the fracture site is still intact. So these are the three types of hypervascular classification. One is hypertrophic non-union. There is hypertrophic trialis that you can see, but still the fracture has failed to unite. That is hypertrophic. Next is horse hoof. The fracture's ends looks like the horse hoof. That is horse hoof. Third is oligotrophic. The fracture callus is so less, even though the vascularity is intact. That is the three types of hypervascular non-union. Now, next is avascular non-union. Because of the loss of blood supply to the fracture side, there can be four types. One is torsion wedge non-union. Next is comminuted non-union. Third is defect non-union. A defect will be there. Fourth is atrophic non-union. So these are the different types of classification. And in an infected non-union, that's a very different scenario and has got a different classification system per se. You need to essentially take care of your infection per se. That is, you need to first give a thorough wound debridement and stabilize the fracture. And as a second stage, you can do a bone graft. And an innovative technique that has been devised is the Ilisaro technique. That is the ring external fixator. That is a Russian method which uses the fractional distraction osteogenesis method. And management of delayed union is prolonged immobilization and electrical and electromagnetic stimulation or percutaneous injection of aspirated bone marrow, which is very rich in mesenchymal stem cells, which can potentiate the bone growth. Next is malunion. So that stops the delayed union or non-union part. Next is malunion. What is malunion? Malunion is fracture healing in non-anatomical position. So this is tibia. This is supposed to be united in a anatomical position. When it is united in a non-anatomical position, you call it as malunion. So you need to know what is malunion, what is non-union, and what is delayed union. So the classification consists of length malunion, whether you get a shortening or lengthening, or a rotatory malunion when you have an external rotation deformity or an internal rotation deformity, and or you get an angular deformity, whether you get a varus deformity, that is your foot goes into the midline, or your valgus deformity, that is your foot goes away from the midline, that is valgus deformity. So these are the three types of classification for your malunion: length malunion, rotatory malunion, and angulatory malunion. So etiology is inaccurate reduction, ineffective immobilization during healing, gradual collapse of comminuted fracture within the plaster, improper fixation of fracture, redisplacement after reduction within cast, growth disturbances due to epiphyseal cartilage injury. So malunion may cause deformity, shortening, impaired joint function, osteoarthritis, and alteration in posture, balance, and movement. There are some sites that is precarious for malunion, like in children. There is supracondylar humerus fracture, which can go for gun stock deformity. See, this is like a gun stock. So that is gun stock deformity. Then Colles fracture in elderly, in distal end of radius, depicts the dinner fork deformity. So basically the management consists of to realign the alignment, rotation, restore the normal length and actual position of the fragment. So the methods include osteoclysis, redoing fracture surgically. That is, osteoclysis means you need to redo the fracture. Basically, whatever the fracture has occurred, we need to redo the fracture by either by manipulation or with any sort of device, and then you need to replaster, or by with a surgical, with an internal or external fixation, you need to correct the deformity. Corrective and compensatory osteotomy has to be done, or excision of protruding bone. Like this figure shows an open wedge osteotomy. See this X-ray shows a varus deformity of the. See, the limb is going towards the midline. So this is what is known as varus genu varum of the knee. Knee is going into the midline. So knee is otherwise known as genu. So genu varum. So what we can do is we can do two things. One is we can do, we can create an osteotomy at this level and and create an open site here. That is what has been done in the second figure. An open site, you can introduce a bone graft here and put plate and screw here. So that has been shown in this figure. That's how we correct the malunion here. That is one way of doing it. Another way is you can remove a bone wedge from the contralateral side. Suppose this is a varus deformity. Take out a piece of bone from the other side so that you result in a straight leg. So the only problem with this procedure is you're gonna get a short limb, whereas the other side you're gonna get a long limb. That's the only difference. Next is what is known as cross union. So this is applicable for a paired bone like your tibia, fibula, or your radius and ulna in forearm. So what happens is that the whatever fracture is there in one bone is going to seep through the introsseous membrane and going to bridge to the other bone and can result in a reduction in supination and pronation. So this reduction in the movement is what is known as cross union. So basically you need to know what is essentially is a cross union. So we have discussed regarding non-union, delayed union, malunion, and cross union. I hope you guys are along with me. A couple of topics remaining. Next is reflex sympathetic dystrophy or pseudex osteodystrophy. So basically, it's a group of disorder which is when there is a dysfunction in the normal injury response leading to an exaggerated response to a noxious stimulus. Basically, there is out of proportion pain. Usually, patients will have pain, but there are some patients who will have pain out of proportion to it. We think that patient will have some psychic problem. It's not psychic problem. It's something very pathological. The thing is that it's characterized by pain, swelling, stiffness, discoloration, hyperhidrosis, osteoporosis, and trophic changes, which are out of proportion to the inciting event. See, when we tell this trophic changes, osteoporosis, hyperhidrosis, all these things contribute to tell that there has to be something to do with the autonomic nervous system. Let's see how is it done. So the precipitating factors are trauma, surgery, or a peripheral nerve lesion, or a stroke. See, for example, a patient is having a distal end of radius fracture. So this itself is a noxious or a painful stimulus. So this pain is getting carried away by the sensory nerves. This is being by the alpha pain route. It is getting sensed by the sensory pathway into the postcentral gyrus, which is the pain sensation pathway. From there, through the autonomic nervous pathway, through the sympathetic and parasympathetic response, it's coming down. Whatever sensations are there, there will be sympathetic response will be there. In some patients, this sympathetic response will be so high that what happens, the sympathetic response will cause additional vasospasm. So already there is a noxious stimulus. So this sensations is going, and the autonomic response is normally in patients there will be autonomic nervous. In some patients, their autonomic nervous system is so sensitive that this sympathetic response will be so much hyper exaggerated. So this causes what is the response of sympathetic system, the adrenaline and noradrenaline on vessels? It causes vasospasm and increased pain response. So this causes additional inflammatory changes on the limb, resulting in burning pain and swelling of the localized area. So again, I've explained the same thing in a better way on the slide. So there's a noxious stimulus which is going into the brain. So from the base of the brain stem, you can see the spinal cord with the autonomic nerve ganglia. Some patients will have increased sympathetic response, which triggers additional vasospasm and pain, which in turn triggers the inflammatory pathway. So this is the basic mechanism of reflex sympathetic dystrophy or pseudex dystrophy. So these are the classification system with respect to the clinical scenario: minor causalgia, minor traumatic dystrophy, shoulder hand syndrome, when you have the affection to the other joint also, major traumatic dystrophy and major causalgia. So the clinical feature is there will be abnormal prominent pain, but pain. Patient will be so severely in pain that he may request you to just amputate the limb. It will be so severe pain. So pain is severe and constant. Patient is intolerant to motion of involved joints, swelling, fusiform in nature because of the additional vasospasm, stiffness of the pain due to the patient won't move the joint. So stiffness and additional fibrosis will be there. Pallor due to constriction of arterioles and atrophic changes because of the uh, additional changes will be there. The nail changes will be there. Loss of hair will be there. Thin and shiny hair changes will be there. And X-ray shows osteoporosis. So this is how the reflex sympathetic dystrophy we can physically diagnose this test, and there will be abnormal sensation for the light touch and pinprick and temperature evaluation. And X-ray shows osteopenia, and bone scan shows increased uptake because of hypervascularity to those to those localized area. So the treatment is essentially you need to have a physiotherapy. You can try for wax therapy, and if it's not, and gradual mobilization. And if the sympathetic block is, and if it is not getting reduced, you can try for sympathetic block and sympathectomy surgically. And next is myocytic ossificans. So it's a reactive lesion occurring in the soft tissue and sometimes in the periosteum, and which is characterized by fibrous and cartilaginous proliferation and by metaplastic changes. It's a misnomer and has got no inflammation. Basically, myositis ossificans means you got a fracture, and the fracture hematoma seeps into the soft tissue and it goes to mature into an additional bone. So it is not an inflammation. Myositis means myos means muscle, itis means inflammation. It's not an inflammation, it's basically maturation. So basically that is myositis ossificans. So, and this results in joint stiffness. So what are the causes? It's trauma, dislocation, massage, or passive stretching of the joints after injury. So any sort of massage or passive stretching following the injury has to be stopped. And areas that is most commonly involved are elbow joint, ankle joint, and shoulder and knee joint. In knee joint, MCL calcification is otherwise known as Pellegrini's Stida lesion, and hip joint and head injuries or paraplegic patients. So basically in acute setting, there will be pain, swelling, and restriction of movements. And in chronic setting, there will be maturation of the swelling, which is characterized by X-ray showing fluffy calcification. So in acute cases, you need to essentially give a splinting of the immobilize the part by splinting. You need to avoid any sort of passive stretching to avoid further progression of the hematoma spread into the muscle tissue. In chronic cases, once the mass is getting matured, you can excise the mass and can put the patient on indomethacin 50 milligram BD, or radiotherapy can be given if there is a chance of progression of the disease. Next is nerve injury. There can be associated nerve injuries along with the fracture. Some of the common nerve injuries. How do we classify nerve injury? One is neuropraxia, when there is physiological loss in continuity of the bone. And this usually, the such sort of nerve injuries usually comes back to the normal within a period of 48 hours to 6 weeks. And when there are anatomical injury to the nerve injury, there are two types. One is axonotemesis, that is your peripheral part of your nerve is getting injured, that is axonotemesis. Next is neurontemesis, that is the nerve body is getting disrupted. So these are the three types of nerve injuries classified by Seddon. Some of the common nerve injuries as being depicted below, as per the site of the injury, like in dislocation of shoulder, axillary nerve injury, which is being most commonly denominated as the regimental badge sign, or radial nerve palsy. in shaft of humerus fractures. So these are some of the common nerve injuries. And how do we manage? Splint the limb, avoid and passive movements of the joints to prevent contractures of the joint, and operative management. If the wound is clean, you can go for primary repair within 6 to 8 hours, and delayed repair if the wound is contaminated between 7 to 18 days, and secondary repair in after 18 days after injury if the injury is seen late or often missed. So these are the types of operative management. Suppose if the patient is presented much later after 6 months and the nerve is irreparable, and then you can try for tendon transfers. And after 1.5 years, even the tendon transfers is also getting and you got a stiff joint, then you can try for surgical fusion of the joint. It is otherwise known as arthrodesis. And there can be injury to blood vessels. And again, the dictum is that you need to give an essentially good compression. Do not try to hold the blood vessel with artery clamps so to damage the blood vessel. And injury to the viscera, like in the urethra, abdomen, or chest injury or intracranial injury, has to be taken care of. And avascular necrosis, that is the femoral head or the scaphoid or the talus. These are some of the areas where you get anastomosed arterial blood supply. So when you get such sort of vascular area, if you get a fracture there, then there are chances of avascular necrosis to the bone, resulting in avascular necrosis. And osteomyelitis. What is osteomyelitis? Osteo means bone, myelo means marrow, and itis means inflammation. So basically, osteomyelitis means infection or inflammation to the bone and bone marrow within it. So this can be further classified as acute, subacute, chronic, and this is characterized by fever, sweating, chills, and rigors. And in acute osteomyelitis, this can be mostly managed by IV antibiotics. Once the pus is self-contained, and you can see on an X-ray, you call it as chronic osteomyelitis. In such situations, you need to essentially debride, and such procedures are known as saucerization and stabilization. And you need to put the patient on antibiotic for prolonged period. So that is the management of chronic osteomyelitis. And there can be joint stiffness, which are further classified as intra-articular adhesions, mechanical restrictions, and osteoarthritis. I hope you guys are bored with my lectures. Thank you for your patient listening. ഷാജിദ്, നിർത്താലോ അല്ലേ?
ഡൗട്ട്സ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ
ചോദിക്കാം. ഓക്കെ, ചോദിച്ചോളൂ. എങ്ങനെ, കമന്റ് ബോക്സിലാണോ വരുന്നത്?
അവർക്ക് അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം.
അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം. Any doubt or open for discussion? മൈൻഡപ്പ് ചെയ്യാൻ തോന്നുന്നല്ലേ ഷാജിത്തെ?
ഓക്കെ സാർ. ഓക്കെ സാർ.